Welcome to today's webinar, SBIRT in Action, Implementing SBIRT into Primary Care Settings. This is being presented by Dr. Chris Farentinos, who is currently Chief Operating Officer for DePaul Treatment Centers, an addictions and mental health agency in Portland, Oregon. So we would like to get to know who the attendees are, and by that we can do some quick polls, and we would like you to participate in these. So the first poll is, what is your current role? Are you a counselor, therapist, social worker, or counselor? Are you nurse, nurse practitioner, physician, or physician assistant? Are you a program or unit administrator, a university student or faculty, or other? And if you'd like us to know what other is, you can either put it in the chat box or the questions box. So we'll have that recorded. And we'll leave this open a couple more seconds. Okay, I think we have a pretty good idea here. I'll share the results with you. And Dr. Farentinos, I'll read these to you since you might not be able to see these screens. 31% are counselors. 3% we have in the nurse, nurse practitioner, physician category. 19% are program or unit administrators. 25% university student or faculty. I think that's one of the highest percentages we've had of that category for a while, so it's wonderful. And then 22% other. So thank you. That gives us an idea of who the audience is. The next poll is, what field do you represent? Are you in mental health, addictions, physical health, education, or EAP? So I don't have another category in this one. Okay, so I'll close this one now. The next two are going to be really quick. Here's the answers for the second poll. 20% mental health, 67% addictions, 7% physical health, 7% education. So that's a really nice spectrum of participants. Now these next two are going to be real quick ones. Do you conduct SBIRT interventions, yes or no? Okay, thank you. I'll close this one now and share. Dr. Farentinos, of the group that we have today, 33% do conduct SBIRT now, and 67% do not. And I have one last poll now. Thank you. Do you see your agency using SBIRT? Do they use it now, or do you see them using SBIRT in the future? This is great. This is the highest group we've had of people who the agencies are or will be using SBIRT. I'm showing 90% of the people attending have agencies that either use SBIRT now or will be using in the future. 10% say no. So thank you very much for participating in that. Dr. Farentinos, I'll now turn the screen over to you. There you go. We should be able to hear you now. And we see your slides. Thank you.
Okay, great. Okay, so, well, good morning. I am in Portland, so it's good morning, but some of you may be good afternoon. My name is Chris Farentinos. I'm going to actually have to correct what my job is right now, but I only shipped jobs 2 months ago. So right now, I'm the Director for Behavioral Health at Legacy Health, which is it's a network of hospitals and clinics in Portland, Oregon, and South Washington. But I was the COO for DePaul Treatment Centers until October of last year. And it was in that capacity that we implemented this partnership between DePaul Treatment Centers and Legacy Health. And so I'll be talking about the partnership, how it happened, what we did, and also doing a brief review of SBIRT, a brief review of the intervention itself. I will show a couple of clips, and then I will share with you the data that we were able to collect with our collaboration and implementation of SBIRT in 2 primary care clinics at Legacy and the lessons learned. I will also have some places during the webinar that I will stop for questions. That way we'll have it a more interactive session as opposed to just all questions at the end. So this is also one of the objectives of the lesson today, is that you will end today knowing what one drink is. But of course I'm joking. So let's take a look at the distribution of alcohol and drug problems in the United States. What you can see in this pyramid is that the top you have severe and substantial substance use disorder that needs specialized treatment. But as you go down, the moderate and mild substance use issues, they can actually be addressed, of course, with brief intervention. And then at the very bottom, no problem in mild, it's only with prevention. So if we are to use the U.S. population of 307 million, which was 2009, we could say that 2 million people, or 0.8%, are receiving treatment today. But another 21 million, 7%, have problems needing treatment, but they are not receiving it. And then about 60 to 8 million people, which is about 20 to 25%, are using drugs and alcohol at risky levels, but not being addressed in general. It's starting to be more addressed through SBIRT implementation in primary care. So once again, in treatment, only 2 million. Now, I would like you to pay attention to where the referrals to treatment are coming. And this is Los Angeles County data, but this is actually very similar in Oregon as well. Self and family, 37%, criminal justice, very high, 25%, other substance use disorder programs, 8%, county assessment center, 19%, healthcare, hospitals, only 3%. But interestingly enough, we know that 60 to 80 million people, they're all going to the hospitals and primary care clinics. So that's what SBIRT is trying to do. So in need of treatment, 21 million reported problems associated with use, but they're not in treatment currently. And a lot of those people did not feel that they need treatment. When there are surveys done, those folks, they normally say, I really don't need treatment, which is another reason for us to realize that to reach them, we have to go where they are going already. They're not going to walk into DePaul treatment centers or another alcohol and drug treatment center. So that from the 60 to 80 million people who do not meet diagnostic criteria, their levels of use indicates the risk of developing problems. So, for instance, drinks 3 or 4 glasses of wine a few times per week, but drinks above the prescribed safe levels for women and men, which we'll get to that in a minute. Or pregnant women who occasionally has a shot of vodka to relieve stress, shouldn't be doing that. Adolescents who smokes marijuana with his friends on weekends, lots of those around here in Portland, that's for sure. Or occasionally takes 1 or 2 extra Vicodins to help with pain. Not a good idea.
Excuse me, could you maybe move a little bit closer to the mic? I just had somebody say that they were having a hard time hearing you.
Yes, absolutely. And I will just
wonderful.
have
That's
to...
great.
Is that better?
Yes,
okay.
much. Thank you.
So once again, these people, 60 to 80 million, need services, but will never enter the specialized treatment system. So I'm going to talk a few words now about what's Oregon doing with these folks and SBIRT. So this is a long story, but I'll make it short. Oregon has created accountable care organizations that are called here coordinated care organizations. And for dealing with the Medicaid population, and the state came up with 17 quality performance measures in which these coordinated care organizations, which are essentially health plans for Medicaid, but really trying to organize themselves in a much more integrated way to deliver accountable care. One of the 17 measures, and those are incentive measures, so the CCOs can actually get money if they achieve certain benchmarks. One of them is alcohol and drug misuse screening, brief intervention, and referral for treatment in primary care. So we're counting beans now here in Oregon. Each primary care clinic is counting how many encounters they have that are SBIRT related, so they can, and that is going into a database to incentivize SBIRT dissemination through Oregon. So are there questions at this time? Anybody wants to say anything?
No, I don't have any questions for you at this time. It was just about the audio was the only issue so far. Thank you.
Okay, so I will move on. So based on the survey, 33% of you are already doing it. But since 67 are not, I think it warrants a brief review of SBIRT. So SBIRT, it stands for screening, to quickly assess the severity of substance use and identify the appropriate level of intervention. Brief intervention, the BI, increase insight and awareness of substance use, motivation towards behavior change, and referral to treatment when the person, the patient meets a threshold in which just brief intervention will not be enough to provide change. So this is another slide showing the SBIRT method. So you start with an annual screen, which is a 1-question or 2-question screen that is a blanket screen done in primary care clinics to all of their patients once every 12 months. If the patient scores positive, which basically means a yes, and you'll see one of these annual screens very soon, we move then to the full screen, which I will also go in detail what it looks like, which is a much more extensive screen for both alcohol or drugs, and drugs. And based on that full screen, if it's positive, there is a brief intervention that should take place, or if the person meets the threshold for a high severity of substance use disorder issues, to brief intervention plus referral to a specialized agency. So one of the things I like saying to folks that are thinking about implementing this, and this is a little bit of the convincing, the buying and the getting the buy-in from physicians, providers, nurses, MAs, clinic staff, is that the SBIRT ranks 4th out of 25 in the list of prevention activities. This is actually a ranking done by the National Commission on Prevention Priorities. This ranking takes into account both the clinical prevention burden and cost effectiveness, return on investment. So it ranks 4th. And it ranks higher than colorectal cancer screening, hypertension screening and treatment, and cholesterol screening. So we're talking about something that yields very good results. And in evaluations of SBIRT, more than 34 randomized controlled trials have been done, focused primarily on at-risk and problem drinkers, not dependent patients. As a result, when follow-ups are done, the result is 10 to 30% reduction in alcohol consumption at 12 months follow-up. So that's quite a bit. And there are many missed opportunities in primary care, because 68 to 98% of alcohol abuse and dependence are not detected by physicians if you don't ask the questions. It's only going to be detected in someone that has cirrhosis of the liver or some other condition that points directly to abuse or dependence. So physicians, in addition to that, physicians are less likely to detect alcohol problems when the screening tools are not used universally. Therefore, the blanket universal screening every 12 months is fundamental. And also in patients who they don't expect to have alcohol problems, like white people, women, higher socioeconomic status, etc. And clinicians, providers, many times, this is a survey that looked at the barriers to discussing alcohol with patients. In our implementation effort here at Legacy, I can say that this was the time constraint was the biggest one, I would say. And the second one was fear that that questioning alcohol and drug would question patients' integrity. So we had to talk a lot about that. It wasn't so much in the belief that patients lie, but in this particular study, that's what it showed. But when you survey the patients on their attitudes, they are okay. If my doctor asked me how much I drink, I would give an honest answer, 92%. If my drinking is affecting my health, my doctor should advise me to cut down on alcohol, 96%. So patients are fine with that. So another compelling evidence is that if a physician sees on average 40 patients per week, 4 to 8 of these patients are going to be, remember that pyramid that I showed you, they are going to be at risk. So 10 to 20% of those 40 patients are going to be at risk. And with brief interventions, 1 to 2 patients weekly are likely to lower their risk. So it's a huge impact that we can make. And here in Oregon, each state will be different, but SBIRT is reimbursable. This is another story altogether in terms of how to get reimbursement, and it's complicated, I can tell you that. But anyway, I think each state will have to have its codes, etc., figured out. And lastly, in terms of cost savings, there are, of course, fewer hospitalizations and ER visits provide a cost savings of about $1,170 per patient. And the cost of the intervention, when you add it all up, is $177. So it's a cost-benefit ratio of 6.6 over 1, very high. Are any questions at this point?
No questions. I guess we just ask that you stay real close to the microphone.
Okay. And is this better? Because I'm trying to figure out where in this computer the microphone is.
Yeah. Maybe when we show the video, could you call in instead of using the computer mic?
Yes, if you give me the phone, I will definitely call.
Yeah, you'll be able to go up to see where we'll open up the panel again, the orange arrow, or the orange box with the arrow in it, and you'll see a section that says audio, and that will have the phone number on it if you click phone. But we can do that during the video.
Okay, sounds good.
Okay, thank you. But no questions.
Okay. So now I'm going to talk about the nuts and bolts of the collaboration. So DePaul Treatment Centers is an addictions and mental health treatment program that has residential and outpatient and has adolescents and adults, treats adolescents and adults here in Portland, Oregon. And Legacy Health is a 6-hospital network of hospitals and over 50 outpatient clinics health system, like I said, in Oregon and South Washington. So we basically approached Legacy. I was at DePaul at that point. We had some contacts here, and we approached them and said, we would love to work with you. Would you like to do a pilot project with us? We started with a very small pilot project, no funding. just basically implementing the universal screen, the one to two question screen, and seeing how that went. And we did it with just 3 doctors, collected some data. They were pleased with that. And then based on the data that we collected on that pilot, we applied for a Care Oregon grant. It's one of our healthcare organizations that is dealing with Medicaid patients. They have an arm that provides grants, and so we got a grant, and we came up with a project in which we would provide screening, brief intervention, and referral to treatment to legacy primary care patients from 2 of the legacy busiest clinics, and through co-locating a substance use disorder counselor at the 2 clinics. It's important to say that the 2 clinics are very close to each other, so they're a block from each other. So she would float between the 2 clinics and be the person there for the warm handoff for the brief intervention. And we would integrate that substance use disorder counseling with the care management team, so she became part of the care management team. And what we wanted to achieve at the beginning is to hire that full-time counselor to provide services at the 2 legacy primary care locations, and to screen approximately 5,000 primary care patients for SUD using the annual screen. And then the DePaul co-located substance use disorder counselor would provide 750 patients with brief intervention. We made these calculations based on the assumptions were that looking at the clinic full attendance, a number of encounters per year, and extrapolating with a percentage that would be positive for their SUD screen, and that the counselor would subsequently apply the second tier screening, the DAST and the audit, which I'll talk about in a minute, and then provide referrals to DePaul and other community-based programs for the patients who screened the highest in the severity zone. So we're going to now just show you a clip, and that shows you not exactly the clinic flow that we have at Legacy, but similar. And I thought that watching a clip is always better than just hearing it. I also want everybody to pick up a pencil and a pen and a piece of paper and write down SBIRT Oregon, just like that, SBIRT Oregon. That website has absolutely every single thing you need to implement SBIRT in your clinic. It has the training, it has the PowerPoints, it has the video clips, it has the instruments, it has the workflow, etc. So, Chris, would you like to take over now?
Yes, just a moment. Here we go. Okay, and right here on this screen is actually the website that we have, and the names of the 2 videos that we'll be seeing. Okay, so let's see how this works. This is
I'm going to talk more about the flow in a minute. So let's just take a look at this particular patient here. So this Mr. Smith's semi-annual office visit. This is actually a true patient. Of course, this is not his face or his name, but this is a patient who is 67-year-old male, married, retired truck driver, came for an annual checkup and hypertension checkup, drinks 3 to 4, 5 times a week, 2 to 3 mixed drinks, but recently drank 5 drinks and could not remember anything the next day. So afraid of becoming an alcoholic like his father, he has said this before to his physician. but did not want to go to AA. The substance use disorder counselor, Peggy, actually did a brief intervention with him, got him to read a NIAAA pamphlet that is called Rethinking Drinking, which is excellent, and got him to also go to a site that is called Moderation Management, in which he agreed to start counting how many drinks he was actually drinking per day and try to reduce. So they had a goal of reducing. So at Legacy, we started with, this is our, the initial, I should say, because we changed it slightly, but this is the initial universal screen. Every patient who walks into Legacy Primary Care gets this survey and answer these very simple questions. And if there is a yes, then they will go to the next level, which is to receive a full screen. So as you can see again in this SBIRT method, there is the annual screen. If there is a yes or a positive, then the full screen happens. And if that full screen shows a certain level of severity, then the patient is invited for a brief intervention, or sometimes a brief intervention and referral to treatment. So the full screen stratifies the patients into zones of misuse. I have to apologize for those of you who have already implemented SBIRT. This is probably old news for you because you're already doing it. But 67% of the folks listening have not. So I felt that this was going to be important to show. And what the full audit and the DAST will do is give a zone of misuse, stratifying that in zones of misuse, 1, 2, 3, and 4. So, for instance, the audit screen for Mr. Clark, he answered some of the questions like this. I'm not going to read through this whole thing, but you know, how often do you have a drink containing alcohol? 2 to 4 times a month. But then he would say 3 to 4 each time. And he has had, number 10, he has had a relative, friend, or doctor that have been concerned about him in the last year. So when we actually do the tallying of this audit, this patient is in zone 2. If you go to that website that I referred to you, the Oregon SBIRT, you will have these instruments there in both PDF and Word with an explanation on how to score them, and a PowerPoint that shows it, as well as video clips that can show you how to do this. It's probably one, I've researched lots of different websites. That one is my favorite. So scoring the audit, there are 10 questions, and each question has 5 possible answers. And so basically, this question here, how often during the last year have you found that you were not able to stop drinking once you have had started? So never, score 0, less than monthly 1, etc., etc. And at the bottom of the audit, you actually add those numbers for each one of the questions. So basically, depending on the zone that the patient scores, you'll be doing zone 1, 0 to 7, just alcohol education. Zone 2 is simple advice. 3, simple advice plus brief counseling, and continued monitoring in 16 to 19. And the zone 4, referral to specialists for diagnostic criteria. So here's the pyramid again that I showed to you at the beginning of the presentation. And this has been a study done in '98, but it has been replicated in terms of prevalence of alcohol use amongst primary care patients. And normally this is the distribution that we find. Healthy drinking, if you will, 78%, 9% in the risky zone, 8% in the harmful zone, 5% in the dependent zone. And so what we really want to do is tackle these harmful, risky ones. These are the ones that when we are able to do brief intervention, that we can actually really get results. The dependent, not so much. They need more than what can be done in brief intervention in primary care. And this is the NIAAA substance misuse threshold that we use in SBIRT to counsel, to do the brief intervention and to negotiate drinking levels with men and women. So safe drinking is 14 drinks per week for men, no more than 4 a day for men, and 7 drinks per week for a woman, no more than 3 drinks in one sitting. And for all ages after 65, it's the same as for women. And of course, you know, what can I say? In the drugs, any illicit use is it's harmful and it's risky. Of course, each provider will have to see each situation, what kind of advice and what kind of brief intervention will be best for those patients. This is a very handy tool that was created by the SBIRT Primary Care Residency Initiative here in Oregon. OHSU, Oregon Health and Science University, got a 5-year grant from SAMHSA to implement in their 7 primary care clinics that they all use residents, SBIRT, and the residents were trained to do that. And so they came up with this tool that I love using here at Legacy. We have implemented in the 5 clinics. Now we went from 2 clinics to 5. We're rolling this out slowly. But we implemented this tool. It's in every single primary care exam room, and the provider or the counselor or social worker, and I'll explain that a little bit more, how we've been doing this here in a minute, but they actually use this tool. So as you can see, you have the categories for drink, you have the limits, and you have a ruler that it's used in the brief intervention using motivational interviewing. The back of this handy-dandy tool is actually prompts for the provider or social worker to what are the components of the brief intervention. So both on top you find the risk zones for the audit and the DAST, as well as the 5 components of a brief intervention, and also a 1-800 number for looking for resources, alcohol and drug treatment programs. So this is a terrible slide because you can't quite see it well. It's kind of fuzzy, but this is the DAST, the Drug Screen Questionnaire. So it's the one that we use if the individual scores positive in the universal screen for drugs. Same way of rating. So do I have any questions at this time? And if you guys have any questions related to, so how did you do this and how did you do that? And you know, feel free to ask questions about how we've done things. I will speak to that in the next session, but I don't know, you know, you may have questions that are not programmed for me to speak to, so feel free.
Somebody is asking about strategies to monitor and sustain SBIRT implementation in a fee-for-service environment.
Right. Well, good question. So in a fee-for-service environment, what I have found here in Oregon is that it has been sustained mostly through grants and in some clinics through successful billing. So, for instance, Oregon Health and Science University dedicated a lot of their time. They had a person, a billing person, that dedicated a lot of their time to figuring out the billing. It's very complicated. It would be an entire webinar, and maybe ATTC wants to do this, because it would be a webinar just on the SBIRT billing and all of the intricacies of it. However, I know that it doesn't cover fully the cost of, for instance, having a social worker or a substance use disorder counselor in the clinic, but I know that it has been done in several clinics here in Oregon, especially because it became a performance evaluation incentive performance metric. Here, what I know is that FQHCs have implemented it, but they are not paid. They're paid differently, and I understand that. At Legacy, it has been through grants, but also through, in some of their clinics, they already had part of their medical home format. They have a social worker who became the person that does the brief interventions. I don't know if this answers, but that's how I can address it right now. Any other questions?
What about brief interventions by physicians that are less than 15 minutes?
Well, that's a big one. We haven't. Oregon as a state has done a kind of an interesting thing, and I think is a step in the right direction, but does not address what you just said. So here's what has happened here. Once the coordinated care organizations were on board and were already being measured in terms of their performance, the state basically said, okay, so you have to, we are going to count the SBIRT interventions by the codes being dropped, by, looking at the billing for SBIRT. And then everybody here got up in arms saying, but look, this is very difficult because we're just starting, and physicians, in order for us to drop the code, physicians have to have 15 minutes to do this. This is not doable. Very few primary care clinics here have social workers or substance use disorder counselors. Give us a break. And so the state decided to allow a Medicaid code to be dropped if a DEST or an audit is done. So if a DEST or an audit is done, the clinic can drop the code whether there was a brief intervention or not. Now, I know that sounds kind of strange because the whole idea is the brief intervention, but it was a first-year initiative towards getting all the clinics to implement the whole workflow and start training physicians and other ancillary staff members to do the brief intervention. The second year, I think, is going to change, and that issue of the 15 minutes is going to become an issue. That's when I go into the subject that just billing, for just being able to drop codes and billing for SBIRT should be a webinar unto itself. And by no means I would be the expert to do that webinar.
Okay. Was the pre-screening questions paper form or built into an EHR?
Can you say that again?
The screen that you used, was that a paper form or was it like a computer form in the electronic health records?
It's a paper form that gets entered in the electronic medical record. Most primary care clinics here in Oregon, at least in the Portland area, in the big hospitals, use Epic, and that's being entered in Epic. So it's the patient does it in a form, a paper form, but that gets entered in Epic.
Okay, and the last question is, what were the CPT codes?
Okay, CPT codes are codes, they are billing codes. So they are codes that hospitals and primary care clinics have to enter in order to bill for anything, office visit, a lab, anything. It's all connected to diagnosis and time, etc.
Okay, that's the last question, and I'm still working on why the video is not coming across correctly, so
Yeah,
we will
have to
do the next one again.
Yeah,
But that's it. You can go on now.
Okay, so I was going to show a video here right now to actually give an example of a brief intervention done by a physician, actually. It doesn't take 15 minutes. It takes about 5 minutes, but it's a very good video. If we cannot show today, I have the slide here with the Oregon SBIRT website, and you can go there and watch it. Once again, it's 5 minutes. It's a very good example of how SBIRT done by the physician can be done in about 5 to 7 minutes, something like that. So, Chris, so we're not going to try to show it, correct?
I don't want to take people's time out for that, since I have a feeling it's going to be the same result. I'm really sorry. It worked on all my tests that I've done. I don't know what's up now.
Go figure. Yeah, well,
yeah.
That's okay. We'll just move on. All right. So this is actually the picture of the brief intervention. Basically, the brief intervention happens with all that I showed you so far. The patient has filled out the DAST or the audit. There is a zone that they are scored. And then the physician addresses that and does a sort of using motivational interviewing, does a brief intervention. Since we didn't see the video about the workflow, let me tell you how it's being done here at Legacy. At the time that the patient checks in to their primary care appointment, they get the paperwork, they get the initial screen, the initial blanket universal screen. At that point, if it is positive, the MA inside the exam room asks the patient to fill out the audit or the DAST. So when the physician enters the room, the audit or the DAST is already completed and scored. At that point, in the Legacy primary care, several clinics that have implemented, it varies what happens next. The VP for the clinics here decided to respect each clinic desire to create their own workflow that would work best for them. With certain providers, the medical provider is deciding to do the intervention themselves. Other providers, and for instance, we have two of the clinics, there are the resident clinics, they're teaching clinics. And the residents, most often than not, do a warm handoff to the counselor, and it can be an alcohol and drug certified counselor in some clinics or a social worker in other clinics, because it varies the staffing level of each one of the clinics. And if the warm handoff is not possible, let's suppose the patient doesn't have time, they need to leave, or somehow the person, the counselor is sick that day, it's always followed up by the social worker or substance use counselor with a phone call. So that is actually a message sent through Epic that triggers a phone call to that patient to see if we can schedule them to come back. If they want to come back just for that, which is rare, that's okay. But many times they say, well, I'm coming back in 2 months. Can that happen in 2 months? And then they schedule that for the next visit. Also, there are some brief interventions being done on the phone. The counselor or the social worker can initiate a conversation about their concern about the medical risks of drinking at a certain level or using drugs. So that can be initiated on the phone as well. And a follow-up letter will follow that phone call. All of that is entered in EPIC in the notes. So that's the flow. So it isn't one flow for all offices, all clinics. I'm going to say just a few words about communication styles and what really constitutes a good, solid, high-quality brief intervention. And it really is different than the physician telling the patient what to do. That we consider as a directing style of communication. If I am a physician and I tell my patient, I really need you to be measuring your blood levels, your glucose blood levels 5 times a day, and this is why, that's considered directing. A guiding style of communication is what has been tested and proven effective in terms of brief intervention with alcohol and drug issues. And that is a hallmark of motivational interviewing, is where you raise the subject, but you actually evoke from the patient their reasons to change. And you evoke from the patient their readiness to change. So this is one of those examples of direct communication that it's the opposite of the guiding communication that I just explained. So the physician goes like this: it's good that you want to stop drinking because you're an alcoholic, and it's important that you accept that you suffer from addiction and develop a supportive recovery network. Here's what I want you to do. Go to an AA meeting every night. This week you can get some names and numbers so you can start calling people. You get the picture. I mean, that is not what we teach providers and social workers to do in brief intervention, because that is the opposite of motivational interviewing, where you're actually evoking for the patient the reasons to change and the readiness to change. I'm going to actually go back just a few slides, if you don't mind, and I'm going to go to this slide here, which is the readiness ruler. So since I see that I still have a little time here, I'm going to tell you one of the ways in which we teach providers, social workers, and substance use counselors to use this tool and to evoke the readiness to change and some motivation to change. So one of the ways the intervention would go would be like this. So Dr. Clark, it sounds like you've been drinking at a risky level. That it does concern me. It's more than what's prescribed by the NIAAA and people that have done research on what are safe levels of drinking. So I do have some concerns, but I wonder, where are you at? In a scale from 0 being, I'm not willing to even look at my drinking at this point, or 10, you know, I'm very much willing to look at it. I recognize it's been a little bit of a problem, and I am very ready to look at it. Where would you put yourself, Mr. Clark? And then Mr. Clark, let's say you would say, well, I think I'm a 7. I would put myself in a 7. And then the physician would say, oh, interesting, you rated yourself a 7. Why didn't you rate lower? What took you to go from lower to 7? At that point, Mr. Clark would start saying reasons to change. So with that intervention, the physician or the social worker is actually evoking from the patient the reasons to change. Because Mr. Clark would say, well, I'm a 7 because my my doctor has said, you had said to me that you're concerned, and my wife also has gotten on my case because I've been forgetting stuff. And the other day I had a conversation with my son, and he was also concerned. And I gained a lot of weight because of the beer. You get the point. He would be giving the reasons to change. So that's my, and then when you look at the back of this instrument, so it kind of guides you through a brief intervention, where if you look at the third line here, enhance motivation, that's exactly what we're doing. We're using the scale to enhance motivation, to pull out of the patient reasons to change, to let them talk about what is it that is worrying them. And then at the end, we always finish the brief intervention with negotiating a plan. So what steps can you take? What steps can you take to cut back your use? Or what are you willing to do? Would you like to reduce? And how much? And how are you going to get there? So therefore, this is a very useful tool to have in all of the rooms to guide the intervention. So I'm going to go forward again. And this isn't, I'm not going to show this to you, but you're going to all be getting the slides. And in this slide, there is a very funny and good example of direct communication that really goes, and you can really see the patient starting to close their bodies and body language. They're like not even paying attention, getting upset because of the directive style. And in the next slide, there is a website, there's a YouTube that you can watch that is a very effective medical intervention with smoking using the guiding style, more of the motivational interviewing style. So I put that in the slides. So if you feel curious to see, and if you're looking at training office staff, etc., these are very fun to watch. They're 5 minutes each. And finally, just a few words about what a good guide will do. We'll ask where the person wants to go, use open-ended questions, inform the person about options and see what makes sense, and listen to and respect what the person wants to do and offer help accordingly, of course. And a few more words about the guiding communication. It's about respect for autonomy, the patient's goals and values, etc. So now I'm going to tell you about what happened in the real world when we went into the clinics and had Peggy, our substance use disorder counselor, hired by DePaul, working at 2 offices, at 2 clinics at Legacy. So I'm going to show you the numbers, and then I'm going to tell you the story behind the numbers. This data was compiled between April 1, 2012 and April 1, 2013. As you can see, you have number of patients seen at the Good Samaritan office. This is total number of patients. And Northwest. Northwest is a very big clinic, much busier, and the total number. And then you have the number of initial. Okay, so when you see the SUD screen, that's the initial universal screen. How many were done? So basically at Good Sam, 53% of screens were done of the total number of patients that were seen, and at Northwest, 14% only. So we immediately, after receiving this data, started looking at what was happening in Northwest, and they discovered that they had just a basic miscommunication with their front desk in how to scrub the charts to find out who needed the universal screen. This was our first year. We are in the second year, but this was the first year, and one of the issues, it was hard getting data from the EPIC. Anyway, don't want to go into that, but it was hard getting data. But look at the numbers of positive screens. So even though it was a low percentage of universal screens that were done on the patients that at Northwest, we had many positive screens. So about 2% was positive, and Good Samaritan about 5%. So there was a 398 total number of positive initial universal screen. But if we counted all of the interventions that happened done by the counselor, the actual counselor that was there to do the intervention, she only did in the whole year 134 brief interventions. And that was really low. So I need to say that in addition to doing brief interventions and warm handoffs, Peggy, the counselor, started developing relationships with some of these patients and started seeing them for short treatment, for brief treatment interventions with 3 to 5 sessions. So it's not like she only sat down with patients 134 times, because that would have been a disaster. So she was doing a lot of work with some of these patients, also a lot of case management, and even going with the patients to the treatment program that she was referring them to. So if she was referring a patient that was meeting the threshold of dependence, very sick, needing residential or outpatient specialty treatment, she actually scheduled to meet the patient at the time of the appointment at the specialty clinic. So she was at DePaul several times, bringing the patients with her. Same thing happened in other agencies. She did that. So she was busy doing a lot of things, but this was a number that intrigued us. These are the numbers of referrals to treatment. So we had referrals to several different agencies, Detox and these other agencies here locally in Portland, Oregon. But of a total of 25 referrals to DePaul, which is the agency I worked and she worked, we could actually follow up on those. And 5 of them enrolled in treatment. So of 25, only 5 enrolled in treatment, even though she was willing to go with the patient and hold their hands to start treatment. Of the 5, 3 patients completed treatment successfully and remained sober, and 1 left treatment prematurely and 1 left treatment but continues in contact with her. We called her here at Legacy, her name, if you will, her title is a resources specialist. We did not want to put the name alcohol and drug counselor because we felt that that could be a barrier. So this is a snapshot of 1 month at one of the clinics, which we started doing this later in the process. We started doing monthly snapshots, which were guiding us much better in terms of following our experiment. And in this case, you can see that they saw 847 patients. 142 of those had the initial screen, but 277 could have gotten it because they were eligible, because they had not gotten one in the last 12 months. And so that was that. We were finding out that we still had workflow issues, and we had a number of positive SUDs. In May was 60, and percentage of patients that needed SUD and got one was only 33%, and number of brief interventions in May only 3. So that is dismal, isn't it? I mean, and that's, I'm going to address this very soon, what we think. Same thing happening in June. We had another snapshot in June. Basically, I will point to this stat here, 29.3% is the patients who needed a SED in June and got one. So again, only 30%, only reaching 30%. Well, this has a lot to do with working the workflow in the clinic. I think one of the barriers and difficulties of this project was basically because both myself, who was project management for the project, and the counselor were not legacy employees. And so that made it more difficult just for us to influence workflow issues, etc. I'll go into my next slide now. When we looked at that year that I shared with you in data, the audit, when we did audit, well, let me rephrase it. When we looked at the audit and the zones that the patients were screening, 43% of the patients who actually got an audit were classified as in the dependent category. But if you stop to think about it, when we looked at that slide way in the beginning, only 5% normally in the percentage of patients in primary care clinics that have been studied, normally only 5% reach that threshold of dependence. And here at Legacy, in these two clinics, in this project, 43%. So what we learn with this experiment is that at first, in this first year, the physicians were only referring the patients to the counselor that were very affected by drug and alcohol. Therefore, in some ways, we were seeing a lot more highly affected patients and seeing less of the lower risk zones that normally are the ones that benefit from brief intervention. I hope I'm making sense to you. I will be stopping soon and you can ask questions about this. So there is a perception that only the most affected patients should talk to Peggy. So the conclusion of that was that the counselor did brief interventions with many dependent patients, but not enough brief interventions with patients with risky and harmful drinking. But those are the patients who benefit the most. So we shared all this data with the clinics, and I'm pleased to say that this has been changing. I don't have the data to show you, but we're starting to collect data now for the next report, and already we can see the trend of a shift in that perception. More patients in the risky and harmful zones being referred for a brief intervention. I'm going to stop here and ask if there are any questions. Are there any burning questions about all this data that I shared?
Excuse me, I have two. First of all, does a substance use disorder counselor have to be licensed to bill for brief intervention?
In the state of Oregon, if a substance use disorder counselor can bill for that brief intervention under the physician, so it's called incident to billing. So if she does the intervention in the same day that the physician referred the patient to her, that is a billable event.
Okay. And the other question is the follow-up letter sent to everyone who received the BI, or only those who screened positive but were not able to receive the BI on the initial visit?
Only to the ones that did not receive the BI during the initial visit. Because during that BI, a lot of the resources and education that will be provided on the spot. And the letter contains the same information. So that's why we chose to send the letter just to the ones that we don't catch in the warm handoff.
Okay, those were the two questions I received since the last time.
Okay. So, so I just have a few more slides to go talking about some of the lessons that we learned from the beginning of the first year to the end of the first year. It was fundamental to have comprehensive and ongoing training with all stakeholders. When we look back, we really regretted that we didn't train the medical assistants and the receptionists in what we were doing. They received just very brief instructions in what was happening. If we were to start, we did do a training with the physicians and certainly with the social workers and substance use disorder counselors. But we went back for the second year and did then more education with the MAs and receptionists. The second big lesson in our implementation is that we went into this a bit naive about the integration of information in the electronic medical record. And I say that because here's the interesting thing connected to 42 CFR Part 2, which is the laws that govern confidentiality in alcohol and drug treatment. If you have a counselor that is working in primary care primarily with alcohol and drug, they are considered a program. So they fall under the 42 CFR Part 2, which means that their notes have to be completely protected from disclosure unless there is a release of information from the patient. Well, that created a major roadblock initially in entering the data, entering the notes, etc., in EPIC. And so there was a lot of work that went into creating a special note that is protected, it's a special function in EPIC that's called sensitive notes. And so it took almost a year to get that done, but it's done now. So when a substance use disorder person, that's all they do is do alcohol and drug counseling and brief interventions. When they are doing their interventions, they have a special place on EPIC at Legacy to store that data, and it can be seen just by the people in the clinic. Because EPIC, especially here in Oregon, we're connected everywhere. So other systems can see EPIC. I mean, there's a lot of connection that goes way beyond the hospital. So that's why. So that was something we went into that naive and came out with an education. On the other hand, a social worker or a physician that works in many areas, and not only alcohol and drug, they don't have the same restrictions. They are not considered a program. So they fall under HIPAA, but they do not fall under 42 CFR Part 2. Therefore, their notes can be in EPIC, which blows me away, blows my mind away, but that's the way it is. So anyway, got an education. Also, the right implementation team was a lesson learned. We had the clinic manager. It was fundamental to have a physician champion. We had, of course, the counselor and myself as a project manager. But we did not involve an MA and a receptionist and an IT person from the get-go, and I would have done that. I would have had information technology, reception, and MAs involved in the very beginning. Of course, physician and clinic management support it's fundamental, and we had quite a bit of that. So it's just fundamental. And I'm going to get to this right outcome definition, and I'm going to take it to my next slide because this, to me, perhaps was the biggest lesson of them all. So here's the biggest lesson. That's the punchline. If I had known to implement this in the day one, I would have done a better job in terms of tracking success, and I didn't do it. So in the second year, we implemented that. So the most important SBIRT QI measures are two. You have to be able to measure the number of annual, when I say SAD, I mean the initial screen. So the number of annual SAD screens completed divided by the number of eligible patients for annual SAD screen. What this is basically saying is, of the people who are eligible to getting a SAD screen per year or per month, how many are really getting it? Are we really doing blanket screening or not? And that took us a while to figure that one out. And the second one is, of course, the number of brief interventions divided by the number of positive substance use disorder initial screen. Because if you screen positive, you get the audit and the deaths, and you have to get a brief intervention, right? So how many people are we really doing the brief interventions? And we did measure that, but we measured it in 6 months. We were not doing it every month. Certain clinics, after I got into this project, I heard of other implementation teams that were able to measure it weekly. That would be optimal, but even monthly, we got into doing this monthly, and it just helped quite a bit the team correct their route and do just kind of mini improvement plans in terms of workflow. So that's, to me, is probably the biggest thing I learned in the first year. Brief interventions are best when there is a warm handoff. It seems obvious, but it's definitely makes for a much better brief intervention. On the phone is okay, but not as good. The EMR, the EPIC sensitive notes, they were fundamental for integration of care. Now all the notes are in the same place. At the beginning, we didn't have that, so we had the counselor writing notes and sending emails, and it was just not effective. Now it's much more effective. Also, the 42 CFR Part 2 issues that I shared. And I cannot stress how much the medical assistant role is important. They make it or break it. In some clinics, we are still debating whether we make the MA the trigger for the brief intervention. Certain physicians are not too comfortable with that. They would like to drive that referral. But other physicians are very comfortable, and they are saying, please, just do the warm handoff. It doesn't even need to come through me, because I would like the counselor to be able to see this patient same day. So it depends which workflow you're going to work with, but the MA role is fundamental. Finally, the counselor at these two programs, the two clinics, being an employee at DePaul and co-located at Legacy was a challenge because, of course, they are part of the team, but they are also not an employee. However, I must say that now we are into this almost 2 years, and Peggy has integrated so well in the team that the Legacy is looking for money to actually be able to hire her on a permanent position. So it can happen, of course, and it takes a good personality. But at first, that was definitely a difficulty. So this is just to show how we're doing this now, that the MA is doing the full screen when there is an annual positive screen, and it's done and scored by the MA. And we had some successes, of course. I find it that has been very successful because the said universal screen has been incorporated in 5 clinics now. We have 23 primary care clinics. It's already in 5 of the clinics, and the plan is to roll this out to all of the clinics. Certainly the awareness about substance use disorders and effectiveness of brief intervention has increased throughout the clinics. Many of the providers have embraced it to the point where they are doing brief interventions and feeling very comfortable with it. And many patients have benefited from both the physician and the substance use disorder counselor in brief intervention. So with that, I arrived at the end. This is my contact information, and I know that this presentation and the slides are going to be put in a PDF format and made available. So are there any other questions or comments?
I have two more questions. Does the MA ask the questions orally or hand a paper form to the patient?
Hand the paper to the patient. Just ask the patient to fill out the form.
Okay. And did any physicians give brief interventions? And if so, what %?
I don't know how to say the percentage. This is a hard one for us to extract from EPIC at this point. What I can say to you is that yes, there are many physicians, but I will not say is the majority. I'm going to say, in my estimate, maybe 10%, 15%. They are the ones who do the brief intervention.
I don't have any more questions, and I thank you so much for putting up with all the little issues we had with the videos. I'm still going to be checking that out. So we really appreciate all your information. This is being recorded and will be in our webinar library, and everybody will get links to that in the morning as well as the PowerPoint. So Dr. Farentinos, thanks so much. I'm going to change this back to me now. I am going to just give everybody a very brief overview of our SBIRT website, and so you don't have to be on that part if you've got other things to do. But
okay, I am going to sign off then. Thank you for the opportunity. I really appreciate it.
So I'll be in touch. Thank you. Okay, so for everybody else, I'd just like to give you a very brief tour of our SBIRT website, and I will give you the link for this tomorrow too. This is our national SBIRT ATTC site, and in it we have a lot of information that you can use, including a lot of the information that she went over today as well. This is our homepage. You can go to training and events to see what other webinars and other trainings we have going on. You can look at our products. This is just a couple here that you can click on, and this will this one actually takes you to the website at IRETA, which is the company or the agency that holds the ATTC SBIRT grant. And in here you can see a lot of information on different topics for SBIRT. And down here in the practitioners section, we have a lot of the screens that she was talking about. And it will show, and it's here's a DAS 10 screen. You can just pull these up and print them off. It takes a minute or so. It's just loading them. So you'll see these different screens that are available. Here's the audit that she was talking about. So these are all available for free downloads. There's a lot of other information here too, as you can see. So certainly please take advantage of that. And then also from our website you can get information on our partners. We have a partner at NORC at the University of Chicago, and then click on their sites to see what they're doing. And they also have webinars available on a lot of really good topics. We have a section for distance learning if you're interested in online education. And this is our e-news where you can register and read the latest e-newsletter, the SBIRT Alert. And this is what one of them looks like. That's our most current one. So if you'd like to get that or another e-newsletter on drug and alcohol issues is called Current. You can just subscribe to that too, as well as the blog that comes out too. So these are all really interesting, and I'm sure that these are items that you would be able to take advantage of. You can also find out about about SBIRT in general, and here's a link to more information. And you can see our advisory board, and also here's our contact information in the staff directory. So this is all really good information. You can also, one thing I forgot to show you is that you can find the trainers in your area. If you're interested in having training at your agency, you can just either put in a name or a state, or just click on a part of the country, and it will come up with the names, and then you can go into the detailed information there and get the contact information for somebody you'd be interested in talking to about local training. So that's my little ad for our ATTC SBIRT site. And at this point, I will close this out. Oh, again, I'll send you the information for this link. And thank you all for joining us. Please fill out the evaluation that you'll be getting in about an hour. And tomorrow morning, you'll get my email with a certificate of attendance, the PowerPoints, the link to the recorded webinar, and also a link to order CEUs, either NADAC or the Pennsylvania Counselor CEUs. Those certificates are $10. And the certificate of attendance is free and will be attached to the email. So at this point, I will close the webinar for everybody. Again, thank you so much for joining us, and we hope you'll join us for webinars in the future.